Hello, everyone. Thank you for joining us for our educational webinar, Why Does My Feet Hurt? Tonight's speaker is Dr. Mark Kolich, orthopedic hip and knee surgeon at OrthoNeuro. Dr. Kolich is a board-eligible, fellowship-trained orthopedic surgeon. He specializes in outpatient total joint replacement, minimally invasive and anterior approach hip arthroscopy, less invasive total knee replacement, and complicated hip and knee revisions. Dr. Kolich will answer questions following his presentation. Please type your questions into the Q&A below at the bottom of your screen. Dr. Kolich.
Thank you very much. I appreciate it. Thanks, Anna. All right, so let's get started. So tonight the topic is why does my knee hurt? So I'm going to go through the anatomy, the treatment, and the surgical journey. So, I want you to feel comfortable to ask questions. So if there's anything that comes up or something that, I cover that, makes you think about something else, or you want me to dive a little bit deeper into, please feel free to put some questions into the box there, and I'd be happy to get to those for you and answer them. Okay, so a little bit about myself. So I am Mark Kolich, Dr. Mark Kolich, so I'm an orthopedic surgeon, like Hannah was saying. I'm fellowship trained and specifically in hip and knee reconstruction. So all of my training is dedicated to just focusing on those two areas. I have offices in New Albany, Westerville, Grove City, and Grandview as well. So if you live in that area, if you don't live in that area, I'd be happy to see you. So education. So I went to medical school locally here at Ohio University Heritage College of Osteopathic Medicine. I did a 5-year residency in Altman Hospital in Canton, Ohio, and then I did a fellowship down here in New Albany, Ohio, specifically honing in on anterior-based hip replacements, less invasive knee replacements, and knee arthroscopy as well. So volumes for me. So I've spent all my energy essentially in this area. So at this point, I've got 4,700 plus hip and knee arthroplasty cases, and that's specifically in less invasive total knees, partial knee replacements. That includes that number actually doesn't include knee arthroscopy. That's just hip and knee replacements, and then minimally invasive anterior total hips. Been fortunate enough to be able to contribute and publish some papers in the Journal of Arthroplasty, New England Journal of Medicine, and the Surgical Technology International most recently. And then I had the opportunity to give some presentations at our academy, American Academy of Hip and Knee Surgeons. It's specifically just fellowship trained hip and knee surgeons, as well as our larger academy of orthopedic surgeons as a whole recently. So let's get into this topic. Disclosures. I don't have any relevant disclosures to tonight's topic. In today's agenda, we'll go through some of these topics here and cover these in depth. I won't go through these one by one, because we're going to go through them here shortly. So good questions to ask yourself. And a lot of times I ask patients these questions as well. And going through everything here, and this is something that the patients come to my office and often have, maybe one of these complaints, maybe multiple complaints. Often, as things progress, it's all of the above. But have you experienced any problems within the following during the last week? Getting out of bed, going up and down stairs, doing simple chores around the house, getting in and out of a car, standing up from sitting. Kneeling is typically a big one, especially with knee pain complaints. Normally the knee is pretty sensitive. If you have issues kneeling, especially with going up or down stairs, is typically the two in particular that I often hear about when folks start to have knee complaints. Having difficulty putting the knee completely straight or bending it backwards, and then unable to pivot. This can also take me down a number of avenues when patients have some issues with any twisting on their knee. Difficulty tying shoes, unable to cross legs, And simple things, just activities of daily living like shopping, whether it's grocery shopping, you're out in the yard, or you're up, for an extended period of time. This typically, if you do have a knee issue, this can exacerbate some of your symptoms. So, the first thing that it's important to is to understand some of the anatomy of the knee and kind of what I'm talking about as I'll dive into it. And I think it's important to educate my patients. And I really go through this, with them in the office. If I haven't seen you in the office already, this is oftentimes what I do with every patient is kind of explain to them, why they're feeling what they're feeling based on what I'm seeing, and then explain everything to them. So the knee in itself is the largest and strongest joint in our body. Is the lower end of the thigh bone, which is your femur, is that upper portion that makes up the top portion of the knee joint. The shin bone or the tibia is the lower portion, and then the kneecap sits on top. So, the inner aspect of the knee, the outer aspect of the knee, and up underneath the kneecap are the three portions of the knee that comprise the three compartments of the knee. And you can have issues in any one of those, and as well as any of the ligaments that are surrounding the knee, which aren't shown in this picture. And then there's also the shock absorbers that sit between your femur bone and your tibia, or your thigh bone and your shin bone, that oftentimes are susceptible to damage or tear, depending on what the mechanism of injury is, or the level of arthritis or extent of arthritis that you may have. So what is a meniscus tear? Okay, so a meniscus is a C-shaped cartilage that sits between those two bones that I was just telling you about. So they're shaped a little bit differently in size, but there are two C-shaped structures that sit and protect the ends of either one of these bones and protect the cartilage, and they are a shock absorber and decreases the load that we transmit across our knee. Okay, so a torn meniscus is one of the most common knee injuries that I do see. It's any activity, in particular, a history with any twisting type injury, especially when you have any load onto the knee. This typically can generate enough force that would cause a tear. The torn meniscus will cause pain, swelling, and stiffness. The tear that's on the upper right-hand portion is what we call a bucket handle tear, and that would typically be the type of tear that would block full range of motion or difficulty with extending your knee. That's not necessarily the case for every patient. There's a number of different types of tears that you can have within your meniscus, and they all present a little bit differently. Not all of them are necessarily operative, and I go through that with every patient, and that's why it's important to have the right imaging and the right workup and the right exam to explain to you why you're feeling what you're feeling and what your meniscus tear, if you have one, what that looks like. So what is joint arthritis? So this is also a common knee complaint, or the most common knee complaint that brings patients into my office. Arthritis is inflammation of your joint that develops over time. Arthritis can make it hard to do everyday activities. Although there is no cure, there are treatment options to help with the pain and keep you active. I put a picture of what arthritis looks like and a normal joint looks like. So a normal joint has articular cartilage on the ends of your shin bone and your thigh bone. Okay, as they articulate, it should be nice, smooth, shiny, like on the end of a chicken bone. Okay, as you develop arthritis and as this worsens over time, you start to get pits, cracks, and these potholes in your cartilage that can give you some grinding symptoms and pain, and you start to develop these bone spurs as a result, as you start to lose that nice, smooth, shiny cartilage. As you lose that cartilage, you also get joint space narrowing and those bone spurs, which we're able to see on the x-rays that we get in the office. So I go through all of these images, although it doesn't look like this. I explain the x-rays to patients in the office and go through that with them. Again, what is joint arthritis? It's the most common form of arthritis. It's a degenerative type or wear and tear type. Where that shock absorber, like I was saying, gradually wears out over time. So it's not necessarily like the picture that I just showed you, where it's, pristine versus, end stage arthritis. there's varying degrees of arthritis where as you start to wear out the joint, you start to have more symptoms. Your symptoms may change over time. You may have more swelling, limited motion, difficulty completing the tasks that I talked about earlier. And this is a result of that bone rubbing on bone, producing pain and symptoms. So symptoms of joint arthritis. There's physical, there's a number of symptoms of arthritis. They're not just physical, right? So we have patients, that come in and have chronic aches and pains. They feel increased temperature at times, limited mobility, stiffness in their knee, difficulty, like I said, going up and down stairs is a big one. Difficulty getting in and out of chairs and bathtubs, and causes sleep disruption, typically on the later end as well. As you get more inflammation and pain and limited motion, you need to get to a very deep restful state, and we move a lot at night. So as we move, this can cause pain in our knee, and that can wake us up at night, and that can be a reason that patients come in to see me as well. Okay. And then this also can cause psychological issues as well, and symptoms for patients, depression. I have a lot of patients that, wait, a long time to come in to see me because they're very fearful of surgery, or that I'm going to tell them that they have to have surgery, but that's not the case. So I'm happy to talk to every patient about, what their knee looks like. I don't push anything on anyone. It's one of those things where I'm happy to provide information for anybody that would like to talk about, what's going on with their knee. Contributing factors. So age, weight, activity level, genetics, abnormal body structure, repeated joint injuries, all of these things are contributing factors to potentially having knee pain complaints. So these are some statistics, and this continues to grow. As soon as they put out a study, it's almost outdated because there's so many folks that are out there that have hip and knee arthritis and complaints. So close to 3 in 10 adults that are 18 and older report having problems with their joints. 21% of them have arthritis. 17% suffer from pain, stiffness, or loss of flexibility. And 54 million adults, and I'm sure that number is higher, like I said, have diagnosed arthritis. Arthritis is the most common cause of work disability in the U.S., and over 700,000 knee replacements are performed yearly in the United States, as well as 325,000 hip replacements. So, and that number is only projected to grow. So diagnosing the problem. So how do we do this, right? So diagnosing your knee problem. Physical exam is by far the most important thing. So it's a combination of things. It's not just one thing that's going to help me come to a conclusion on what may be going on with your knee. It's your X-rays, with your exam, with your history, what's worked for you, what hasn't worked for you, and kind of go from there. So physical exam is by far the most important. I always get X-rays on all of my patients. Patients that have a certain history that may make me think that there's an isolated meniscal tear, I oftentimes do get an MRI. CT scan, bone scan are less useful for diagnosing arthritis, and typically the first two can be accomplished from an imaging standpoint between X-ray and MRI. And then oftentimes I will get laboratory tests or have that performed on patients that I am concerned that they may have an autoimmune type of arthritis rather than the degenerative type that I'm speaking today. So treatment options, okay? So there's non-surgical and surgical treatment options. So, and I talk to patients about all of these things, right? So, non-surgical treatment options. So you always want to make sure that, it's low impact exercise that you're performing, right? So I want you to be active. I want you to be out there. I want you to move your joints. Okay, so the only way that your joints get nutrition is through what we call diffusion, where the joint fluid inside the knee joint passes directly over the cartilage to help it stay healthy. So if you don't move, those patients typically do have issues with their joints more so than someone who is active. Now, high impact activity can be harmful for your joints. So low impact exercise is what I promote. So yoga, swimming, cycling, all those things are good for our joints. Okay. certain dietary supplements and alternative medicine. That's something that patients do ask me a lot about. Our academy in particular is mixed on whether it's helpful or not. I often tell patients that if you do take a supplement and you think that it's helping you, like glucosamine, chondroitin, go ahead and keep taking it. Okay, but I don't back it or push it or say that you have to take that. Okay, weight loss is a big thing. So losing weight, there are some great studies that are out there that demonstrate that even small weight fluctuations and decrease in weight do substantially improve how patients perceive their joints to feel and their activity level overall. Okay. I often enroll patients in physical therapy to keep their knees strong, and gear that physical therapy specifically to what their issue in particular may be. Okay. Bracing is an option for certain patients with certain type of knee issues. So that's something that I do talk to patients about, and prescription medication. So this is very patient specific, especially with current medications that patients take, what they're able to take, what they're not able to take, and how much pain and inflammation and what they had been taking previously, whether or not I throw that into the mix. Okay. Assistive devices can be very helpful for patients, especially if they're fearful for falls, or if they're not able to undergo surgery if it's bad enough. This is something that I will implement just to ensure that they do not have an issue in the meantime until we're able to optimize them to be able to undergo a procedure. Okay, and then joint injections. Joint injections is probably one of the most common conversations that I do have in the office with patients, and I will go through some of those. And then surgical options. Okay, so there's arthroscopy as well as joint replacement when it comes down to surgery. So arthroscopy is going to be indicated for a patient that does have an acute meniscal tear, okay, and their cartilage for the most part is going to be very healthy. Okay, I do tell patients that it's very common. I have this discussion often where as your joint starts to wear out and the cartilage starts to narrow, and that joint space starts to narrow, it also pinches down on the shock absorber or the meniscus, and that can tear the meniscus. So that is one of those things that we do see with patients. As you start to wear out your joint, it's very common to see a meniscal tear with advanced arthritis as well. And those patients are not typically indicated to undergo a knee arthroscopy procedure. So joint injections in particular. So I do have a lot of discussion with patients about the onset of pain, how much swelling that they're having, what they've done before, what's worked well for them, how did they respond to it. So I take all those things into consideration, in which in particular these apply to each patient. But corticosteroids in particular is a great pain reliever. The duration of action may not be as long as some of the other injections. There are some long-acting steroids that can be approved, but they can be a little bit more difficult. But for the most part, the corticosteroids work very well for patients to decrease inflammation and pain, and they can be safely performed every 3 months. Okay, so there are some studies that are out there that can be harmful for your joints if you're undergoing injections into your knee in a short period of time. So we want to make sure that we're staying away from doing any of those things in a short period of time, because we would not want you to be that small subset of patients that have issues doing that too soon. As for hyaluronic acid, that's probably one of the most common conversations that I do have with patients about hyaluronic acid injections, or the gel type of injections, as there's a lot of commercials that are out there now talking about these things. But the hyaluronic acid injection is something that would have to be, for the most part, approved by your insurance company, as they are relatively expensive. So normally, every insurance company is a little bit different, but most of them do want to see that you failed other forms of conservative treatment before we implement or attempt to go down this path with hyaluronic acid or the gel type injection. These gel type injections, once they're approved, they're either a series or a one shot type of injection, just depending on the brand, and they all essentially work the same. And the nice part about them is that they do lubricate your knee joint, and it stimulates the lining of your knee joint in and itself to make more of that natural lubricant over a 6-month period. So the patients that have that mild to moderate type arthritis are typically the patients that respond the best to this, rather than the patients that are bone on bone and end stage in nature. Okay. And then I also do have the discussion with patients about platelet-rich plasma, or PRP, which is something that, I think that there's more and more research that's coming out with this. So I am having this discussion more often in the office. And I do think that there's some really good data that's out there that's showing that these patients are doing well. And the whole concept behind this is that, this is your sample, right? So this is blood that we draw in the office that we're able to spin down and take the concentrated portion of your blood that have all the growth and healing factors. Those growth and healing factors, when they spin them down, those platelets are activated, and those platelets that we put back into your knee are able to, or theoretically, bring all of those growth and healing factors to your knee to decrease inflammation, to decrease pain. There's some studies that are out there that state that it increases hyaluronic acid production as well. So there's some really good studies that are coming out now at this point in time that are comparing directly to steroid injections, directly to hyaluronic acid injections versus a placebo. So in every patient, the difficult part to study about platelet-rich plasma injections is that every patient is different, right? So every sample is going to be completely different. So as we, draw one person's sample and spin it down and offer that to them, the person sitting right next to them may have a different response. So the important thing with these is that we do not take any anti-inflammatories that would affect our platelets prior to undergoing this injection, right? Because we want our platelets to be fully functioning and undergo this route. Okay, so there's more data that's coming out about this, but I do have this discussion often with patients now, more so than even a year ago, about this as an option for their knee pain. So when you have joint pain, when should you consider knee surgery? So this is something where I go through this discussion with patients. So this is something that's affecting your quality of life, your activities of daily living. You're to the point where you're having more bad days than good days. And all of these other things are no longer providing you with pain relief, okay? And you're having swelling, you're having limited range of motion. And despite the conservative treatments that are offered, you continue to have that quality of life that is dipping as a result of your knee pain, okay? So, and that's, and then I put at the bottom there, and you have tried other treatments for a reasonable period of time, okay? Now, if it's an acute meniscus tear that you have and it's blocking your motion, every patient's a little bit different. So there's obviously exceptions to the rule. It's not, every patient has to wait an extended period of time and be miserable to have surgery. So I have this discussion with everyone. And I think, the best way to go about it is a shared decision-making model with patients, and that seems to make everyone happy. So surgical treatment options. So arthroscopy. Okay, this is a look at the joint. The first thing that we do is we look into the joint. You have two small little portal incisions on either side of the knee. And this is typically how we treat meniscal tears. Okay, so we put a small camera in there and fill the knee up with some fluid so we can see. And then we find and identify the meniscal tear, and then we just take enough back so it's back to a smooth, stable border. So those patients recover very quickly. They're up on their feet right away, and normally it's minimal downtime, okay? Partial and total knee replacements are also available. Joint replacement is not appropriate for all patients, okay? Partial knee replacement, I have up in the corner, top right corner, and then total knee replacement. So partial knee replacement is indicated for a subset of patients where there's arthritis only in one of those three compartments, okay? And a total knee replacement is if there's arthritis that are involved in the other compartments in the knee, and you have end-stage bone on bone, and you fail all of those other treatment options, okay? But we replace those ends of the bone with metal components, and we provide a new plastic cushion that addresses this bone-on-bone pain and mobility. Okay, so you get your motion back. Again, you are putting all your weight down on this the day of surgery. So I have all my patients up putting all their weight down on it and working with physical therapy. The whole point of having a knee replacement surgery is to get you up and get you moving and increase your quality of life. Okay. So what are the goals of a new joint? Reduce pain, improve quality of life, regain strength and mobility. Okay. While generally successful, some patients will continue to experience some pain during levels and activity restrictions. For the most part, this is a temporary thing, and unless there's other things that are going on, most of these patients that are having partial knee and total knee replacements are very happy, especially when you wait to the right time and patients come in and say, I should have done this a long time ago. Normally that's the right time. Okay. So joint replacement success. So there's a lot of new technology and designs. Okay. So I spent like I said, all my time and energy, doing hip and knee replacements. So it's fascinating the things that we have out there that are available for patients anymore. And this continues to evolve. And I'd love to be at the forefront of all that. Okay. So the new software allows all surgeries to be templated and planned prior to entering the operating theater. So I plan every surgery out for all of my patients prior to them entering the OR. So I have an idea on exactly what I'm looking at, implant sizing, and assessing your potential deformity. Okay, and recorrecting and reconstructing. There's new advances in minimally invasive approaches and rapid recovery protocols that allow patients to return home safely with less restrictions post-operatively. So this is a big one too. I mean, it's come so far from 20, 30 years ago. And we used to put patients in a step-down ICU after a joint replacement procedure, and then send them to the floor after a few days, and then they were there for a week, and then they would go home or go to a skilled facility and then go home. This is something where these patients aren't sick. You're not sick. This is something where you have a bad hip or a bad knee, and that's it. Okay, for the most part. So there are unique cases, but those patients, who are healthy that have a bad hip or a bad knee, they're able to go home safely, especially with the advances in the rapid recovery protocols where patients are getting up and moving and they're comfortable doing it, and are able to go home. So risks of joint replacement surgery. So joint replacement parts are still subject to wear and tear, just like the real joints. So, that plastic cushion that sits in between there is subject to wear, although the newer polyethylene post 2004 has an incredibly low wear profile. So the plastic that's out there now is fantastic. So I mean, really, patients, that's not really as big of an issue that we're seeing anymore, or that I'm following. Okay, the life of any implant will vary based on health, weight, activity level, and other variables. So it's multifactorial. It's not one thing in particular that's going to determine the longevity of your implant. Okay. And then you should discuss these and other risks with anesthesia. And I always have that discussion with patients that you do need to talk to anesthesia, beforehand, and they assess you beforehand as well as I, before undergoing any of these procedures. So what are the stages of a joint replacement? So the number one thing is that we want to make sure that these are elective procedures, right? So we want to make sure that you're optimized. We want to make sure that you're healthy. We want to make sure that, you're going to come out after your procedure and do very well with this. So we want to make sure that we time this up appropriately. We coordinate our care with our primary care physicians, and make sure that you have the adequate workup prior to ever entering that operating theater. So it's nothing but a positive experience, and that you're going to thrive with your new knee. Okay. So the day of surgery, this is something that patients typically show up in the early morning. Over 97% of my patients show up in the early morning after the procedure, which typically takes around an hour. They're going home sometime in the early afternoon, unless you don't have the adequate help at home to be able to go home on your own safely. Okay, and then the recovery period, for the most part, they vary a little bit between partial knee replacements, total knee replacements. Typically, partial knee replacements. If you're a candidate, you do see quicker recovery compared to a total knee, but overall they both do very, very well. Okay. A total knee replacement is around 6 to 8 weeks full recovery. Most of the time when I'm seeing patients back in that 3-week office is that they're continuing to thrive and really take off. Physicians educate patients and families about arthritis treatment options and joint health and recovery through smart lifestyle choices. Ultimately, the best way to make sure that we have a successful recovery and that patients do well is working together. Okay, so patients, doctors, caregivers, we all partake in making sure that everyone's on the same page. We all understand what our goal is, and we're very clear and communicate very clearly on what to expect. I'm really big on trying to alleviate any anxiety leading up to a patient's surgery, just to make sure that we're very comfortable, and I want to create an environment that patients feel comfortable to ask me questions, to make sure that we don't run into an issue because they think they're going to ask a question that may be silly. Okay, there's no silly questions. So preparation before surgery. Education. So like I said, educate patients, families, and I often encourage patients to tour the facility. I think this is really big on decreasing anxiety. Know where you're going, know where you need to be the day of surgery, and help you sleep a little bit better the night before surgery. Okay, like I talked about, health optimization, pre-admission testing, glucose control, which is your blood sugar. Okay, which is an important one. Weight loss, smoking cessation, blood pressure control, and potentially a dietitian if indicated. Okay, and then like I said, planning, is a collaboration. It's working together to make sure that the plan makes sense, that everyone's on the same page, and that this is something that everyone is very comfortable with. Okay, and then certain exercises that or prehab essentially that may help you before and after a knee replacement or knee scope anyway, or arthroscopy. All those things are important to increase knee stability, and it does make a difference. Okay, the day of surgery. Okay, the process, I go through that with you. I talk to every patient about what that'll look like for them in particular. Okay, pain management. I go through a number of different multimodal treatments, and this is part of that rapid recovery protocol. This is one of the big things that's really changed for patients, where I do a number of different things to make sure that you're able to recover quickly and decrease your pain overall. And I really think that it helps with the patient experience around the time of surgery. So between you're completely asleep for this procedure. Okay, this is not something that you'll be awake for. Okay, I typically do a spinal because I believe in decreasing pain receptors before we ever do a surgery, and this really has helped with pain control apps afterwards. I also use a numbing medication around the surgical site that lasts for 72 hours or 3 days. So most patients, as they're leaving, they feel very comfortable for 3 days, and this really helps with physical therapy, helps you get moving, and once again, patient experience. And then in addition to that, if necessary, IV pain medication if you're on the floor. And most patients, I'm sending them home on oral pain medication, with the same medication that you would get in the hospital. Okay, patients, I want them up out of bed the day of surgery. Like I said, this is the whole point of having this done, is to get you up and get you moving and back to living your normal life. The quicker that we get you up and back to normal routine, those patients typically do much better, much quicker. Okay. And then I talk to the family. I talk to the family immediately after surgery. I keep them updated. I go over how everything went, and I do the same thing, the following day with patients afterwards. Okay. Communication is really big. And I think, focusing on that and keeping everyone in the know is very important. Recovery, make it your goal to recover at home. So this is something that, I do feel that, having that one-on-one care with your family, or friend, or whoever it may be, at your home after your replacement, it is really important. You're very in tune with what's going on, with those patients. Like I said, as long as you're safe to go home, and I go through that in detail to make sure that you are in fact one of those patients prior to, ever to sending you home, because I want to make sure that you're safe. But But at the same time, this is something where, patients are able to go home and you get great care at home, and, you're up moving around on your own. Most of the time, your knee feels better after you go home than it did prior to your surgery. Okay. And it's just those first few days, that we see patients that need some of that help. And then normally they're taken off pretty quickly after that. It's just those first few days getting to and from the bathroom and helping you make meals. Okay. So your support system is very important in your recovery process. Understanding which medications I want you to take in which order. I do give a number of different medications in small doses. Okay. And they're geared to be able to avoid having to take any heavier narcotic pain medication that can affect your bowels and affect your ability to move and stability. Okay. So, the baseline medications are important, and you still get those other medications that are just there for breakthrough pain. Okay. Recovery, activities that you can and can't do. And that's where therapy comes in really important to educate you on those things. And then diet and rest. Okay. And that's one that we don't really highlight. But rest is really important. Okay. I mean, these can be bigger surgeries where, patients, their tissues are healing, and you need to take adequate time to be able to heal and ice and elevate. And, and then once you get through that initial period, these patients are very happy and, back to living the routine that they were accustomed to. And that's ultimately their goal. Okay. So for more information, speak to your primary care physician, or me, or anyone with OrthoNeuro. And then I listed a phone number here to call for an appointment. If you'd like to see me, I'd be happy to see you. And I listed the offices there as well. So thank you for tuning in.
Thank you, Dr. Kolich. We've got a few questions that we'll go through now. So our first question, it says, what is the movie sign, and why is it related to a meniscus tear?
What sign?
The movie sign.
I'm not familiar with the movie sign.
I'm not sure. We'll come back to that one if it.
McMurray, maybe they were trying to type McMurray, maybe just auto text. So McMurray is a test that we do to see if we can reproduce pain, basically. So what we're feeling for is along that joint line where that meniscus sits, whether it's the inner meniscus or the outer meniscus, and we put the knee through some range of motion, and we're trying to reproduce pain. And that's just a name of a test, essentially. So if you have a positive McMurray's, it would be one of those things that would make us think that you may potentially have a meniscus tear. The most sensitive finding that's out there is joint line tenderness. So actually me taking my thumb and moving it across your joint line and feeling along where that meniscus sits is the most important. Okay. And then if you have any mechanical type symptoms of catching, locking, snagging, that's typically, for me, that's what makes me think, okay, well, maybe we should think about ordering an MRI. Okay. And then seeing if there's something that's going on with your meniscus.
Next question is, will surgery stop my arthritis?
So, so if it's a joint replacement procedure, the purpose of a joint replacement is to eradicate the arthritis. So, yes. So after a knee replacement, there is no arthritis because we, essentially resurfaced the areas where there was bone on bone, loss of cartilage, those bone spurs, those will all be gone. Okay.
And the next question is, can you take out a bone spur?
Can you take out a bone spur?
Mm-hmm.
Yeah. So, with a knee replacement, that's a part of a knee replacement is we do clean up that joint surface, and we do remove the spurs that are there. It's not something that we typically do through a knee scope or the knee arthroscopy that I was referring to. So it's not that procedure in particular. It's a replacement that would remove the spurs.
How bad does my arthritis need to be before you recommend surgery?
So, that's one of those things that I was talking about. Ultimately, the measure that I look at is quality of life. Okay. So quality of life is the biggest measure, right? So if you have a huge dip in your quality of life and you are not responding to conservative treatment, and we've gone down those paths where, we've tried potentially therapy, bracing, injections, medication, and you're not responding to it, and you're having more bad days than good days, then, I open up that discussion to patients to say, hey, maybe we should start thinking about, what this would look like for you. But they all do have to line up, right? So it has to be their exam, their x-rays, and, failed prior conservative treatments.
How long can I wait until I have a knee replacement?
So, I tell every patient, I won't tell you that you have to have your knee replaced. I don't push surgery on anyone. That's a decision that they have to make for themselves. But I help them make that decision based on, the things that they're telling me to get to that point. Okay.
If I'm overweight, can I have knee replacement surgery?
So, that's a difficult question. So, it's one of those things where, I do have that discussion. The big thing that I focus on is optimization, right? So it's not necessarily the patient's weight, it's how healthy they are, right? So if you are heavier, but you're unhealthy, it puts you at risk for other things around the time of surgery. Okay. So we want to minimize risk, okay, with surgery. Weight can be a risk, more so with wearing out the joint itself, but not necessarily as much for some of the other things. Now, if the patient, does have an elevated BMI or weight, and they've got a slew of medical issues on top of it, that's one of those discussions that I have with patients to say, hey, look, based on the numbers, your risk would be right around here. Okay. And then I help them make that decision on whether or not to proceed. And, sometimes some hospital systems, if the BMI were so high, sometimes they in fact have, said no to me. So that's pretty rare, for the most part, but, it's not weight that I'm just looking at.
Okay. And how long do knee injections last?
So everybody's a little bit different, right? So, whether you've had an injection or not, okay, how severe your arthritis may be. Typically, if you have more severe end-stage arthritis, you're not going to respond for an extended period of time, and they're not going to work as well because your knee is going to want to stimulate more inflammation. It's going to generate more pain because that wear and tear is more substantial. Okay.
What about stem cell therapy?
So there's stem cells that are out there. I didn't mention that in the injection, portion. There's not enough good data that's out there on it. PRP is starting to really build, and there's more information that's available out there. I still think that it's too early to potentially offer stem cells to patients at this point.
Can I choose if I have a total or partial knee replacement?
So that's one of those things I would provide the recommendation based on if you're a candidate or not, right? So that's something I typically get some specific views to make sure that you don't have arthritis on in the rest of the knee. Okay, and I have this discussion. If you are a partial knee candidate patient, I have this discussion the day in the office as well as the day of surgery, where I'm still going to look at the other side of the knee. And if there's a major issue with the cartilage on the other side of the knee, then they're going to end up getting a total knee replacement at that point in time. Okay, because they would not do well with a partial knee replacement if they have a big defect in their cartilage on the outer portion of the knee. But that's about 1 in 20 patients. Okay, so it's a very low number, where you would end up with a total knee, versus having a partial knee replacement.
Do you do meniscal repair?
So meniscal repair are typically indicated for patients who are younger and the tears that will heal. Okay, the tears that will heal are tears that are in the outer portion of the meniscus. Okay, the blood supply to the meniscus on the outer portion is more robust, so it has the potential to heal. If there's a tear that's on the inner portion of the meniscus, it typically does not heal appropriately, and it will fall apart essentially over time. So that's a decision, that we're able to make once we're able to look at the tear under the scope. But we have that discussion prior to ever entering that operating room, because it can change your recovery, okay, and your weight bearing status afterwards if you have a repair versus having a partial meniscectomy.
Can I have a knee replacement outpatient?
Absolutely. So if you're a good candidate, okay, so and I have this discussion, every patient is different and has unique social situations, medical history. There are more patients that are good candidates for outpatient knee replacement. It is patient specific, and I do have that discussion. I want to make sure that you're safe going home, but a lot of patients are able to go home and have the comfort of their own home after a hip or knee replacement.
How long is the recovery from knee replacement?
So a total knee replacement is around 6 to 8 weeks. For the most part is what I tell patients. So if they're planning on taking any short-term disability, I tell them to take 8 weeks of short-term disability if they have a heavy labor job. Now, if you have a desk job or you work from home, you certainly could get back to work much sooner than that. Partial knee replacements are typically sooner than that. So most of the time, I see patients back at 3 weeks. Most of them don't have assistive devices, no walker, no cane. And I see them back at 6, 7 weeks, and they just sort of taken off at that point.
And the next question says, what would be the best option for a 90-year-old patient with osteoarthritis who is too old and can't have surgery anymore, and cortisone shots have not helped?
Yeah, so every patient is, depending on their medical history, age is a number, right? So that patient could be 90 and be functioning and active, like somebody 20 years younger. So I've operated on a number of patients that are 90 plus years old. Okay. And that's part of where that training comes in. There's other factors to consider, with bone density and things like that, but it's certainly not something that I would rule out solely based on a patient's age, that they're not a candidate for a surgery.
So how old was the oldest patient you've done a total knee replacement on?
I think 102.
How long is the recovery time for a partial tear surgery?
For a partial, like a meniscus tear?
Yeah.
The recovery is very quick. The recovery overall, most patients, they get a numbing agent in the knee as well as a block in the knee. So the knee is numb for that first day. So I typically protect their weight bearing until they're able to kind of feel and get some feedback from the knee. But normally it's a few days, where you're up, the knee's just a little bit sore early on. But normally when I see patients back at that 2 to 3 week, portals are healed up and they're already back to their usual routine, within that first week of having their knee procedure done.
What is the optimal weight for joint replacement?
The optimal weight. So we want your BMI to be lower, right? So the lower your BMI, the less stress you're going to put across your joints, and the lower the risk is from a statistical standpoint. As long as your BMI, is lower than, there is no ideal number, honestly. That's a very difficult question to answer, because there's a lot of things, and patients carry their weight differently too. Because your BMI can be, 30 and, somebody else at 30, it looks completely different. Right. So, and then I have some patients that have a BMI of 50, but they're a bodybuilder. Right. So, BMI is not necessarily a great number, to look at just with, it's more body habitus and all those other factors that are combined. Okay.
What is the possibility of reoccurrence of a tear after surgery?
So, that's a difficult question too, right? Because the quality of tissue is a little bit different for everybody. The type of tear is different for everybody. So, really that's a question that you would ask after you have your procedure done, how big was the tear? If the whole meniscus was taken out, the recurrence rate of a tear, would be 0, so versus, if it was a tear that kind of ran, front to back, or was more of a degenerative type, which typically happens with arthritis, then your recurrence rate for a tear would be relatively high. So that's why we typically don't do, knee scopes on patients that have arthritic knees, because as that joint collapses down, it pinches all of the structures within that knee in itself.
All right, we have one more question left. If there are any other questions, feel free to put them in the Q&A box. But the last question we have so far is, what are the benefits of outpatient surgery?
So the benefits of outpatient surgery, like I was saying, those patients that are able to go home, I personally, you have that one-on-one care, right? So you have a family member that are there, and you're able to get back to your normal routine, right? So you're not in the hospital with everyone else that is potentially sick, okay? Because you're not a sick patient. So going home on an outpatient basis, you're not stuck in the hospital with everyone else and around everyone else that may be ill. The patients that are having hip and knee replacements on an outpatient basis are healthy folks that just have a bad hip or a bad knee. Okay, you're going home with the same pain medication, and typically patients, like I was saying, rest. You typically get better rest at home as well. Okay, so there's a lot of positives, with going home on an outpatient basis, and there's some very, very large studies that have looked at the patients that have gone home on an outpatient basis. It is a very safe thing to do with the joint replacement procedure. And the biggest thing is alleviating anxiety and fear for patients in the office, because like I said, they have this thing in the back of their head that they remember back when they're, so-and-so had their joint replacement done and they stayed in the hospital for a week or two. So this is a safe thing to be able to send patients home on an outpatient basis, and education and being on the same page with your surgeon, your family, and your support team is really, really important. So all those things combined, and it's really it's been a special thing. So I think the overwhelming majority of my patients that have gone home on an outpatient basis, have been really, really happy. Okay, and I think that me being able to offer that to them is a huge plus. Okay, and it helps with a positive experience in these patients' lives. So this is routine for me. This is a big deal for patients that haven't had their hip or their knee replaced and don't know what that looks like. But this is what I do every day, and I'm passionate about it, and I really care for patients. And I think it's for me right now it's the best thing for my patients. So that's why I would say it's better than being in the hospital and having an outpatient hip or knee done.
And then I have a follow-up question to that, is what if you live alone?
Yeah, so if you live alone, that's a contraindication, right? So we're not able to send you home because that wouldn't be safe, right? So if you live alone, you're not able to have that person in a very early period to be able to help you if you needed to get to and from the bathroom, have you help make meals. So that is one of those contraindications where we would have to keep you and work with the case management team to either send you to a rehab facility or skilled facility, or keep you in the hospital long enough that we could send you home with home health potentially. And that's also an option, okay, where they come to the house and help you, with therapy and things of that nature.
And then it looks like we got one last question.
Okay.
If you have surgery on a knee, what is the possibility of having surgery on the other knee?
It's about 50%, honestly, for the most part, and I generally will tell patients, what the other knee looks like. Normally when I get x-rays of say you come in for your right knee, I also include the left knee in the image just for comparison. So it's one of those things though, it's ultimately a quality of life call. Okay. I don't tell patients that they're going to follow some timeline in particular. I tell them, look, this is the way that it looks. It may bother you, may not, so everyone's activity, their demand's different, their pain tolerance is different, so, and I help make that decision with them, once it becomes or makes sense for them, based on where their quality of life is.
Okay. Thank you to everyone who asked questions. They're all great questions. And then, thank you so much, Dr. Kolich, for presenting tonight and answering all those questions. Our next webinar will be on September 1st at 7 p.m. Neurosurgeon Dr. Mark White will be speaking on how to manage low back pain. Look on our social media pages for additional information to come. Thank you to everyone for participating in the webinar tonight. Have a good evening.
Thank you.